The Senior Rehab Project is supported by the Game Changers, a group of motivated rehab clinicians that are crushing mediocrity and advancing care for older adults. You can join this group of people and get access to the private Facebook group, the monthly meetup with article discussions, and have a say in the direction of this movement. Get off the sidelines and get involved. Just go to seniorrehabproject.com/Game Changers. Hit me!
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Hi there, Senior Rehab Podcast listeners. I'm Tali Spaceman.
I'm Erinn Carey.
And this is Senior Rehab Project Shorts. How are you doing, Erinn?
I'm doing quite well. How are you, Tali?
I'm good. Today I want to talk about something that is a little uncomfortable usually to talk about, or even painful, and pun intended, and that we all as people that work in the medical field and in the medical system deal with almost every day, and it's the opioid crisis.
Yeah, no, let's get heavy.
I want to get heavy from the start.
Yeah, right? Let's waste no time feeling sad.
This is why I'm not good at first dates, because I'm like, and what is your thought about the opioid crisis?
Oh, God. Hashtag Tali's first dates.
This one was published in JAMA Surgery in 2017 in August.
Ooh, new.
Drug-free interventions to reduce pain or opioid consumption after total knee arthroplasty, a systematic review and meta-analysis. It is a JAMA Surgery original investigation. It's almost like an original Netflix.
I was just thinking it sounds like CSI. Original investigation, JAMA Surgery.
Okay.
I would binge watch that for sure.
Inadequate post-operative pain management has profound acute effects, as you know. It has an effect on the immune system. It suppresses it. It can cause DVT because people do not move enough.
Because they're in pain.
Yeah. And because of lower mobility, it can also cause pulmonary embolism, myocardial infractions, and pneumonia. And there's also the long-term influences of poor pain management that can include people taking meds for longer than they should, making acute pain into chronic pain. And in the end, it could cause opioid dependence.
So I think that's a really nice, succinct how the opioid crisis happened, or at least a contributor to the problem we have in this country with opioids.
It is definitely a contributor. So the first line of therapies to treat post-operative pain are pharmacological, including anesthetic, opioids, and acetaminophen.
Makes sense to me.
Yeah. And nobody says that it's the wrong way to do it. Nobody says not taking medication is the answer. Actually, other research has shown that postponing the meds when you need them will cause dependency because the level of pain will rise and then you're like, okay, I need all the meds. And this is why they try to keep pain under 3. And when it reaches for 3 and above, this is where you should take the medications. Usually, I have to say that this is not a recommendation by a doctor.
Wait, what is it?
That I'm not making any recommendation for anyone to take meds right now.
I see. Oh, that's probably smart to get that out of the way.
Yeah,
But it makes me think about a lot of my post-op patients that I see that are like, I don't want any opioids, So they take a Tylenol and then they really can't do well in therapy and then they end up needing them more later. It's the exact same thing you're talking about.
Yeah, because that's what happens.
Mm-hmm.
It's improper use in general that cause improper use of the other side. You either take too little or not taking it all, and that will cause you to take more when the opioids are not the most effective.
An aside is that's technically polypharmacy by one of the definitions. Inappropriate use. Yeah. Call back to another Shorts episode.
Yeah. So this is a systematic review and a meta-analysis to evaluate the effectiveness of commonly used drug-free interventions for pain management after TKA. So they gathered RCTs on post-operative pain.
Cool.
And they use Prisma.
Yes, love Prisma.
I know. I as soon as I saw it, I'm like, oh, Erinn's gonna love it. They use Prisma.
Wait, did they also use Prospero?
Yes.
This is a great review, guys.
And they also have really beautiful tables. I found your soulmate in an article. So they researched all the big database, PubMed, Ovid, Cochrane Central, Register of Science, Pedro, and clinicaltrial.gov. They also used some gray literature and did what they call a snowball.
What's gray literature?
Gray literature are things that people did for like their doctorate.
Oh, so stuff that's like not published in JAMA, but are out there.
But was like introduced in conventions and people did the research, but it wasn't published.
Pretty sweet.
And also use what they call a snowball technique strategy. Is like the one leads you to another. It's almost like a rabbit hole.
Yeah, that sounds like my Saturday nights. That sounds like that's how I look. How I learn about things. Like I start reading and then I find the reference and I look at the reference and then I just like hop and skip.
They use post-operative pain or other ways to spell it, like post-operative and stuff like that. And total knee or total knee arthroplasty or total knee replacement or TKA. So those are the only two terms they used.
Wow, that's pretty... Well, how many articles did they come up with?
They came with more than 5,000.
Of course they did.
Yeah. Because it's almost like searching knee.
And that's my search strategy.
Primary search objective addresses the PICO, which is patient interventions, comparators, and outcomes.
Takes me back to grad school.
The P is patients that are undergoing primary TKA. I is in the intervention, non-pharmacological treatments for pain management, plus the usual analgesic therapy.
Cool.
C, other non-pharmacological interventions or no intervention, plus usual analgesic therapy. O, the outcome, post-operative pain relief, and opioid and NSAID consumptions. Okay?
And opioid and NSAID consumption, like after or during, or like the need for more?
The during and after, how many meds did they take? Was there a reduction?
I see.
Yeah.
Okay.
Cool. Study selection, non-pharmacological interventions with routine pharmacological treatment, either with other non-pharmacological approaches or with only routine pharmacological treatments. So it sounds complicated, it's not.
Yep, I'm confused.
So the treatment was pharmacological plus non-pharmacological.
Like either pharm versus no pharm.
So it was non-pharmacological intervention plus pharm, because you cannot not give someone meds.
Yeah. So
it's the two of them versus only pharm.
Wait, so non-pharmacological like physical therapy or like just some other treatment that does not have to do with drugs.
Yeah.
Got it. Okay. I was confused. I was thinking that they weren't giving them medications, but at the same time they were. And that didn't make any sense.
Think that they're giving anyone medications as needed or as prescribed.
Right.
The only difference is that the treatment group got also a non-pharm intervention.
Cool.
And the other one didn't.
Okay.
Or the other one only did the routine pharmacological approach.
Nice.
Okay?
Cool.
There were 3 researchers that went through all the articles.
All 5,000.
No, so it's not the whole 5,000s. They reduced it to 120 and then some more. Like they went over 120. And how did they establish things they didn't agree on?
Oh, let me guess. They discussed it.
They're discussion, but a discussion that is approved by Cochrane. Okay, so the 3 researchers independently screened all articles by scanning abstracts or portions of the text. So the interventions that were included were CPM, which is continuous passive motion, preoperative exercises, cryotherapy, electrotherapy, and acupuncture. And those are all the things that, they searched the database from 1946 to 2016.
Sweet.
And those are the things that came up.
Nice.
Yeah. The earliest article is from 92. It's not that impressive.
Still, 92 is a while ago.
Yeah. And I want to say that they did a good job explaining the theory of each one of those interventions in the article. They did a little segment of what is the theory and with references and stuff. And it was really nice. I have to say about this article that it's really readable.
That's cool.
Yeah. And the tables are pretty.
Yes. Wow, I really love this article so far.
I feel that all you're looking at me is how pretty I am.
It's your tables, baby. I love you for your tables. But it's the content that matters.
So post-operative pain relief was defined as the mean difference in scores on visual analog scale, the VAS, or on WOMAC, which is the Western Ontario McMaster University's Arthritis Index Scale.
Cool.
So it's people that went through a TKA, so it's a
They're going to have
valid and reliable WOMAC. Opioids and other analgesic consumption was evaluated in terms of mean difference in consumption of morphine equivalents in milligram per kilogram per 48 hours.
Nice and standardized. I like it.
Mm-hmm. While other analgesic consumption was evaluated as the mean difference in the number of tablets they took.
Okay.
Also, another thing that showed up in some of the article is the time before they used the PCA machine, the patient control analgesia machine.
That would be a really easy bit of data to collect.
Yeah. Data analysis, I'm not going to go in. It was pretty good how whatever was in median, they used the standard deviation to convert to a mean.
Cool. Sounds statsy.
Yeah, it was pretty nicely done. Results. So the search yielded 5,509 studies. Of which 120, which was like 112, came because of the internet database, and 8 more were added from the snowball and hand.
Cool.
Yeah.
That sounds awesome.
I thought it was cool. I don't know why.
I like it. It's unique. It's something I haven't, I don't think I've seen that in any other reviews.
Yeah, that somebody admitted, hey, I found this nice article. I'm adding it to my review.
Yeah, because snowballs.
Yeah. It's actually something they use in social studies.
Oh.
Yeah.
I like
They
it.
use it more in social studies.
Cool.
They read the 77 RCTs in extension, and they extracted 39 RCTs for the meta-analysis. All from 91 to 2015. I don't know what happened to the other 81 studies, but I didn't ask.
Did they have a Prisma flowchart?
They didn't have the Prisma flowchart.
It's probably on there.
And they did a good job, so I just believed them.
Oh, that's dangerous.
I know. I know. I'm taking my chances.
I would like to recommend you not do that in the future.
I know.
That's fine. No judgment.
A pool total of 2,391 patients were examined in all the RCTs.
Dang.
And they categorized the 39 RCTs basis on 2 outcomes, which is pain relief and opioid or analgesic consumption.
Okay.
And the 5 interventions.
Nice.
Yeah.
I can't wait to see these charts.
See, they are pretty.
They're beautiful.
Also, I want to say that there were so many countries the research came from. It came from Australia, from Canada, from Norway, from Taiwan, from the United States, from the United Kingdom, from South Korea, from the Netherlands, from India.
That's amazing.
It's
nice work.
Yeah, I like that. I like inclusivity. I like when no one country thinks it's the center of the world.
Huh.
So they included 18 studies on CPM, 3 studies on pre-operative exercises, 12 studies in cryotherapy, 4 studies in electrotherapy, and 4 studies on acupuncture.
Nice. That's like a really nice spread.
Mm-hmm. There are a lot of CPM, and I have to say that you can see which methods are easy to use, because CPM, you practically just put a patient on a machine.
Yeah, if you have the machine, it's like easy.
And cryotherapy, you just put ice on a patient.
Cryotherapy.
So you can see that you had 18 and 12 for those, and 3 on preoperative exercises.
Too much work.
Too much work. And also, it's not a thing for pain relief. It's more for functional and
preparation.
Mm-hmm.
Still.
And bias. A lot of bias.
Yeah.
They identified that the highest bias studies was due to improper absence of masking during the study.
Wait, if they're randomized controlled trials,
it's really hard to mask somebody's on a CPM machine.
You're right. That's a good point. Or the ice pack is going to be cold.
Yeah, I mean, most of the things that use ice, they also use compression, so at least there's some sensation of something on you.
Yeah.
But it's really hard to know, am I doing preoperative exercises or no?
Yeah, and I guess with the design you were talking about of non-farm plus farm versus farm and nothing.
Yeah.
If it were non-farm with nothing,
mm-hmm.
you could just give them a placebo tablet and that would deal with that sort of blinding, but you can't do that.
Blinding is really hard when it comes to PT.
Yeah.
There were also 13 cases that studies had bias for selective outcome reporting.
13.
Yeah. So, pain relief and analgesic consumption. They did found that the quality of evidence was of low certainty to very low certainty for pain improvement in all interventions.
How do they define low versus very low certainty? Is it like a statistic or something?
Yeah, it's in the table. It's a statistic.
It's in the table. You shut your
in the
questions
table?
up.
No,
No, that's a bad
I
one.
do want...
It's okay. I'm teasing. It's okay.
See?
It's in the table. There it is.
Whoop. There.
Whoop. There it is.
See.
Right now, Tali is showing me the table.
And like...
Oh,
It's a pretty
effect
table.
estimate. It's so pretty.
Yeah.
You guys, Google this table.
Okay, so meta-analysis of 2 pain relief studies, which had 129 patients, suggested significant improvement in experimental group versus control with electrotherapy, with mean difference of 1.95 on VAS at 1 month, minus 2.34 on the VAS at 2 months, and 2.6 on VAS on 6 months.
So it seems like initially there's a big decline in VAS scores, and then it kind of like evens out. It flattens out a bit from between 2 and 6 months.
Yeah, a little bit, but still there's more improvement.
Yeah, it's still happening, just not as quickly.
Meta-analysis of 3 studies showed significant improvement in the experimental group for acupuncture, with mean difference of 1.14 on the VAS at 6 months.
Cool.
And meta-analysis of the other studies showed very little significance for cryotherapy and nothing on the CPM. So CPM does not really help with post-operative pain.
Yeah.
Now I'm talking about the amount of opioids that are consumed and not about the amount of pain.
I see.
Acupuncture and CPM showed no significant difference between the experimental group and the control group when it comes to opioid consumption.
Wow.
And they both were too low and very low certainty.
Huh.
However, time before PCA in 2 studies is shown to be significantly increased with acupuncture.
Okay, so it's like not a delay in magnitude, but a delay in need.
It's in delay on the time instead of taking
the time. Yeah, sorry.
Instead of taking it at 4, I'll take it at 4:46 because it's 46 minutes later. So for the discussion, and I want to read this, our findings suggest that electrotherapy may not only reduce early pain, but also change long-term trajectory of recovery from pain after TKA, which is very important. It's not only about the pain, like, they did check 6 months later and not only the 1 month.
Are they talking about TENS? Or are they talking about like FES? Just TENS?
Because...
or is it different types of electrotherapy?
Yeah, because EMS was considered still as acupuncture. And that's why I think there were some things that were like good with the acupuncture.
Because it's acupuncture like TENS.
Yeah.
Interesting.
And I think that sometimes we don't give electrotherapy enough credit. Yeah, because we think, I didn't learn PT to put someone on a machine and go sip my coffee. But it is a useful tool for some things.
Yeah. I mean, there are definitely patients that I've seen in the past in the outpatient setting where like they were in so much pain. So basically we addressed their pain and then we were able to do more.
Mm-hmm. So they found evidence that electrotherapy changed the pain severity at 1, 2, and 6 months.
Cool.
Yeah. With increasing effect size over time. So over time, it did have better effect.
That's really cool.
Mm-hmm. So electrotherapy might be considered effective as a non-pharmacological ancillary intervention to standard pharmacological therapy for long-term pain improvement.
Cool. I'm definitely like taking notes of this for my TKA folks.
Cool. Do you have anything to say?
Oh, actually, you know what? I want you to give me like 3 bullet points that I can take away from this article for our listeners and for me.
So electrotherapy is a good thing to use with your patients for if the goal is to use less medications and to alleviate pain.
Cool.
And again, I'm only talking about TKA pain. Post-operative TKA pain.
Yes.
Because pain acts differently.
Yeah, that's true.
And I think that it used to be the problem that we treated all pain as the same.
Right.
And they are not the same. Not every chronic pain is similar to other chronic pains. Not every acute pain is the same as other acute pains.
Right.
I mean, like, you can use it. It's not harmful, but it's not very useful.
Yeah. Maybe use it if you've exhausted your other options.
I don't know. I'll still use it because the patient will look at me funny if I won't use it. All right. So I want to end with a quote from the discussion.
Do it.
As prescription opioid use is under national scrutiny, and because surgery has been identified as an avenue for addiction, it is important to recognize effective alternative to standard pharmacological therapy, which remains the first option of treatment. Our study provides modest but clinically significant evidence that electrotherapy and acupuncture can potentially reduce and delay opioid consumption.
Love it.
Now, I want to say something. What I think is that I think that if we scream opioid crisis, we need to give a solution. We cannot just scream opioid crisis and not come, okay, what do we have to replace that? Because people are not going to just be in pain.
Yeah, no. And if they are, if we were just to take opioids out of the equation, a lot of people would have unnecessary suffering.
Because I'm a little afraid with that, and it is a crisis and we really need to deal with it. I wish we had dealt with it 20 years ago.
Truth.
When it was growing. But we cannot just scream crisis, and I think we're causing another crisis. If we're not going to deal with this crisis well, we're just going to cause another crisis with other people trying to take off their pain by drinking or trying to take things that are not opioids.
Yeah, I mean, the hospital system is already really overburdened with these patients who are on these opioids, or like they had a surgery, they started taking opioids, the doctor took them off, they moved to heroin, now they're on methadone, and now they can't get into a subacute rehab because they have a methadone addiction. Mm-hmm. And all the while they're sitting there, their pain management is not being well taken care of, and they're suffering, and they just have to sit there in the hospital. And it's really horrible to see. Like, it's already starting. The next crisis.
Yeah, exactly.
So offering solutions, I think, is the absolutely appropriate thing to do.
Offering solutions, and the solution is never, don't take opioids.
Yeah, that's dumb.
All right, so this is it for now. I'm Tali Spaceman.
I'm Erinn Carey.
And this was Senior Rehab Podcast Shorts.
Yes, it was.
Yes, it was. You can find us on Facebook. You can find us on emails. You can find us on Twitter. You can find us on Instagram.
Yeah.
Thank you, Nicole, for doing all the social media.
Nicole's a social media beast.
She's really great.
Yeah. We want to thank the Game Changers for supporting us. They are the ones that allow us to do what we do. So if you are interested in getting off the sidelines and in on the action, you should join the Game Changers group by going to seniorrehabproject.com/Game Changers.
You can also find us in CSM and join us for a beer one day.
Yo, can we? Let's hang, guys.
All right.
Good team.
All right. And as always,
stay funky.
Hit me. Thank you for listening to the Senior Rehab Podcast. If you only listen to these podcast episodes, you are missing out on 90% of the Senior Rehab Project. Hop on over to seniorrehabproject.com where you can join the movement that's advancing care for older adults. You can join for free or become a part of the Game Changers where you can get some free gear and access to our monthly meetup. Just go to seniorrehabproject.com. I appreciate y'all, and I'll talk with you soon. But in the meantime, do not forget to stay funky.